Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto, the host of Medical Society of Delaware's podcast, Delaware Healthcare Reality. We have a guest today, Dr. Anthony Vasile, who will be talking to us about sleep apnea. But before introducing our guest, I'd like to give you a brief editorial. We at the Medical Society are trying to collect data regarding the burdensome process of prior authorizations in an attempt to show the inefficiency of this process. As you know from the podcast on prior auths that I've done a few months ago, the majority of physicians see no benefit from this costly and time-consuming process, and many believe that this process is partly responsible for the so-called physician burnout. Also, patients have expressed concern that their health is at times affected in an adverse way, leading to delayed care and sometimes adverse outcomes. So physicians, be aware that you may be receiving a questionnaire addressing these issues from the Medical Society, so please respond. And if you are a patient and have had problems with getting a prescription medication or testing, please email the Medical Society of Delaware at Delaware Healthcare Reality at medsocdel.org. That's Healthcare Reality at medsocdel.org. And now our topic for today is sleep apnea with our guest, Dr. Anthony Vasile. Dr. Vasile received his bachelor's degree from the University of Delaware, magna cum laude, his medical degree from the Philadelphia College of Osteopathic Medicine, with his internship and residency in internal medicine at the Osteopathic Medical Center of Philadelphia, followed by a fellowship in pulmonary medicine there as well. He studied with Calvin Stafford at Crozier Chester Medical Center in sleep medicine, and he is board certified in internal medicine, sleep medicine, and pulmonary critical care medicine. He currently serves as the medical director of the Delaware Sleep Disorder Center. And now our guest, Dr. Anthony Vasile. Hi, Tony. Long time no see.
How are you doing?
We go way back, don't we?
We do.
We do. I remember when I was an intern in Riverside Hospital, and Dr. Vasile came down as a student, and we had a good time. He's a fun guy to know, and we got along very well. He's presently retired from pulmonary medicine, and he's enjoying his retirement. I remember I called him a couple of weeks ago, and he was out fishing with the gang, some of the old people from Riverside. Did you catch anything?
A lot of bluefish.
Oh, yeah? Are you catch and release it? Do you bring them home to eat?
No, we release them.
Catch and release?
Yeah.
Where were you? Out the coast or where?
We were.
Where was it? Hatteras? Oh.
Yeah, there was no drumfish this year, so.
Okay. Well, enjoy it. All right, now, let's talk. What is sleep apnea and how does it affect patients' health? And can you distinguish the difference between central and obstructive sleep apnea?
Sure. So sleep apnea is a disorder that occurs, primarily it's obstructive sleep apnea. Mm-hmm. That is where we tend to focus primarily. Central sleep apnea we'll talk about, but it's pretty minor in terms of what we see in terms of percentage of disorders. It's out there and we do see it. But obstructive sleep apnea occurs when we fall asleep, we begin to get relaxation of our upper airway. So if we completely collapse the airway for a period of 10 seconds, that's called an apnea. Mm-hmm. And the other thing that we know is that if there is not a complete collapse, but a partial collapse, and there is a drop in the oxygen saturation in the blood of a few percent, 3 or 4%, that's a significant event, and they're called hypopneas. Mm-hmm. If you have a combination of the two of more than 5 per hour, you have sleep apnea. So there are degrees of apnea. Mild apnea is 5 to just under 15 events an hour. Moderate's 15 to just under 30, and over 30 is severe. So typically, what are the health implications of sleep apnea? there are several. One, there is sleepiness, tiredness, fatigue, which can lead to other health issues, safety issues. We know, for instance, if you're sleep deprived by a couple of hours one night, that's the equivalent roughly of having 3 beers. And if you stay up for 20 hours, it's the equivalent of being drunk from a reaction standpoint. We know that fatigue from sleep apnea has a higher incidence of mortality on the road than does distracted or drunk driving. There's about 5,000 to 8,000 cases a year of mortalities from apnea that's untreated. So that's the one end of it. The other end of it are the other health issues. We know that when you have an apneic event or a hypopneic event, the brain senses either the drop in the oxygen level, and we take in oxygen, we metabolize it, and we make carbon dioxide. And so our brains are very in tune to keeping those levels, or particularly CO2, carbon dioxide, at a certain range. If it starts to drift up, the brain senses that and sends what we call a sympathetic discharge, or in lay terms, an adrenaline surge, to respond, to get the patient to awaken, so you get airway tone back. And so those events, those adrenaline surges, can lead to inflammatory responses. So it causes surges in blood pressure. It can lead to heart disease, diabetes, higher incidence of stroke, cardiac issues in terms of rhythm disturbances. If you have underlying coronary disease, there's a higher incidence of sudden death occurring during the night.
That has happened in a lot of sports.
Yeah, I think Reggie
athletes.
White was one of the ones. And so that's kind of obstructive apnea. Central apnea is a different animal. Central apnea occurs when the brain decides it's not going to send a signal to breathe. Typically, breathing for us is completely involuntary, right? I mean, you can't hold your breath and die. So what occurs with central apnea is, again, you have these periods where you stop breathing for a period of approximately 10 seconds minimum. And it's because there's lack of a signal to breathe. The upper airway is open. It's what we call patent. And so, but central apnea occurs from a couple of reasons. One is chronic opioid therapy. Narcotic therapy does this. Folks with prior brain injury, whether it's prior stroke, issues like that. Sometimes we see a little bit of central apnea at high altitude, but that typically goes away quickly. And then the other cause is significant underlying heart disease, typically congestive heart failure. And so folks who have central apnea with congestive heart failure have a significantly higher mortality than those who do not.
Can central nervous system issues such as myasthenia gravis cause this, as far as you know?
Myasthenia gravis is a peripheral neurologic condition.
Correct.
So typically with myasthenia, that would be not the brain sending out the signal, but typically the myasthenics or folks with, we can see this, for instance, in folks with other neurologic disorders where they'll develop respiratory failure, hypercarbia. So it's a little bit more of a complicated issue that's related to the respiratory mechanics.
Gotcha. All right, what are the particular symptoms of sleep apnea, like obstructive sleep apnea, that would clue the physician, us on the primary line, to pursue the diagnosis. I know, everyone says, "Oh, I snore." Does snoring always mean sleep apnea?
No.
Okay. Witnessed apnea events by wife or
Yes.
husband or something in that regard is a reason to do that. And nocturnal choking or paroxysmal nocturnal dyspnea, where you stop,
Yes.
boom. That's a good enough signal to us to start to think about it, but there are other things that would lead to, there's other things that we would look into a patient to figure out what they have, and is it life-threatening or is it potentially dangerous. Sleepiness, for one. I always ask my patients, are you refreshed when you wake up in the morning? That's a good question, right? And then do you take naps in the afternoon? Things like that would be one. You know of any other things that would trigger us off to figure it out right away or no?
Well, one of the things that is a good screening tool is when it's history and physical, right? So that you brought up history, tiredness, fatigue, snoring loudly, witnessed gaps in breathing at night, some other behaviors at night potentially, waking up short of breath, waking up with headache in the morning can be a clue. The other thing is the physical end of it. So when you're examining the patient, if you look in the mouth, right, and you see that the airway's crowded,
Mallampati score.
The Mallampati score, which we can get into, which we can talk about, which we will talk about, is the Mallampati score. Large tonsils, difficulty breathing through the nose. Is their jaw recessed? In other words, what we call retrognathia, where the jaw is recessed. The other consideration is if you see a palate, the soft palate, the uvula that hangs pretty low in the back, or it appears that the AP diameter is pretty shallow. That's been my experience. So they're the things you can that help. Now, getting back to the Mallampati score, it's an easy enough test to do. Just have the patient sit straight up, open their mouth wide, and stick their tongue out as far as they can without saying ah. If you can see all the structures in the back, the tonsillar pillars, the uvula, that's a Mallampati 1, which would be normal. If you see nothing, it's a Mallampati 4. Mallampati 3 is that you can see just a little bit of the base of the uvula, and then Mallampati 2 is where the tonsillar pillars are partially obstructed.
Gotcha.
And so as you go from 1 to 4, there's a much higher incidence of apnea in the 3 and 4s. Now, the Mallampati score was primarily developed for anesthesia.
Right.
Because folks who have high Mallampati scores can have more difficulty with intubation and waking up, or not waking up, but airway issues post surgery. But you bring up the easiest thing to do in screening patients, in my view, is the stop bang score.
All right, we'll get to that. I have one more question on Mallampati score.
Yeah.
I recommend that I have a picture of the Mallampati scores, and I explain to the patients what this means and that you have a higher risk because you're at a 3 or a 4. And they understand that. I say, you can't see your little uvula hanging down here, right? No, I can't see it, and that kind of thing. But that's a good screen for us in the primary care level to look. Right. Now, the stop bang. Now, this is a simple questionnaire.
Well, let me just say one thing, commenting on Mallampati. When you look at the AASM, the American Academy of Sleep Medicine guidelines, it's a thorough history and physical.
Exactly.
So a Mallampati 1 doesn't mean you don't have apnea. It's still about the other factors. There are plenty of people walking around that are 120 pounds with a Mallampati 1 that you have to, everybody, we assume, oh, you don't have apnea, you don't look like you have it. Then you ask the question, do you snore? Oh my God, I have to leave the bedroom at night. I'm tired during the day. So it's not just, you can't just rely on one thing.
Exactly.
And when you talk about sleepiness, there we can get into it after we talk about stop bang. There's what's called the Epworth Sleepiness Scale. But the stop bang is the easiest thing in the world to do. And one of our nurse practitioners who doing his doctorate program studied the Mallampati score as how do you increase screening for sleep apnea in the primary care office, and he used the stop bang score. So the stop bang is like it's spelled, STOPBANG.
Mm-hmm.
S stands for snoring. Do you snore loudly enough that people hear you through a closed door?
Mm-hmm.
The T is, are you tired? Are you fatigued during the day? And realize there's a difference between tiredness and or fatigue and sleepiness, right?
Mm-hmm.
Fatigue is I don't have any yawn. Sleepiness is I got to take a nap.
Right.
Or is there O is for observed apneas, and then P is for pressure. Are you hypertensive? If you are hypertensive, you have a higher incidence of sleep apnea. Matter of fact, folks with sleep apnea have about a 3 to 5 times higher incidence of developing hypertension.
Okay.
And then the BMI, body mass index, right,
Mm-hmm.
which is now in all the EHRs, right?
Yep.
You don't have to calculate it. If it's over 35, you get a point for that. If you're over 50,
Big
if you're
point.
a male, and then one thing we didn't talk about was neck circumference.
Right.
In a male, it's 17 inches, higher incidence of apnea. Female, 16 inches.
Got
So
it.
if you have 3 or more of those positive,
Mm-hmm.
there's a 90% chance you have at least mild apnea.
Mm-hmm.
So we can talk about who needs to be treated and who doesn't need to be treated, which we can
We
do
will
that
as we
down the
go.
road as we
Mhm.
go. But the thing is, how do you make it? A physician with the time crunch on, they come in, they got diabetes, hypertension, they want to talk about anxiety. You're not going to ask them the stop bang. Where the stop bang is really effective in increasing screening is if the patient does it in the waiting room or the person checking them in, the MA, they can do the easy part and then somebody can look at, you can fill in they can fill in the BMI,
and next size.
and that if you have a 3, that patient needs to be screened.
Got it. So, we got a simple way as primary care doctors to screen for this stop bang, which is a simple questionnaire. We have the Mallampati score. We have the weight, 35 BMI and above, and we have the neck size in men, 18 or 7.
Right, yeah, for the stop bang.
Okay.
Yeah,
And the Epworth sleepiness scale.
yeah, it's a little bit.
It's intense, more intense.
Yeah,
as a
it's more
screen.
intense,
Yeah.
and it's fairly simple. It's you ask a series of questions,
Mm-hmm.
and those questions are: do you fall asleep while driving? It's a point scale.
Okay.
So the answers are never, slight, moderate, or high.
Mm-hmm.
So, and the questions are, what's your chance of falling asleep sitting and reading? That's one question. Watching TV is the second question. Sitting inactive in a public place like a theater or a meeting. Lying down in the afternoon when circumstances permit. Most people would, probably answer to that.
Mm-hmm.
Positive. Sitting, passenger in a car for an hour without a break. Driving stopped in traffic for a few minutes, sitting and talking to someone. I joke and say, as long as it's not your spouse. And that's it. And then sitting quietly after lunch, as long as no alcohol has been consumed. I mean, so if you have 0 to 24, the highest is 24. We feel that 10 and above, or some people feel 8 and above, means you're too sleepy.
Got it.
But again, we use the Epworth scale more. In the primary care setting, you're not going to be doing an Epworth scale. We use it more to gauge how effective is treatment, right? If we're treating somebody for sleep apnea or for what we call hypersomnia, narcolepsy, it's a way to kind of trend. But it is very subjective, right?
Mm-hmm.
I mean,
Yes.
so
So, in other words, if you're out on a date and you fall asleep, you probably know the date's not a very good, exciting person, and you probably have sleep apnea. Just a joke. Okay. All right, we've already talked about some of the health risks, but sudden death is always, what's the percentage of that? Do you know?
I don't know.
Okay.
I mean, we do know that, most sudden death occurs between midnight and 6 a.m.
Mm-hmm.
Okay, and that in there was a couple studies done. There was a study done that looked at sudden death and examining those folks, and that 46% of them, and they had prior sleep studies. 46% had sleep apnea, and only and 21% did not have sleep apnea.
Okay.
So again, it's a marker, and also what's the severity of the apnea, right? I mean, we know that folks who have coronary disease are at higher risk for sudden death.
Because it has adrenaline surge that occurs,
correct,
right?
Yeah. Mm-hmm. Whether it's rhythm, whether it's myocardial ischemia. And a lot of that is tied to, how, where's the oxygen level in this? In other words, how much do you desaturate, and what time do you spend with an oxygen saturation of less than or equal to 88%? Mm-hmm. There are people with horrific apnea that have no significant hypoxia. Then you have people that have more mild to moderate apnea that they have significant desaturation. So it's not
clear cut.
Yeah, it's not clear cut, and some of the research today is looking at these apneic phenotypes. Mm-hmm. Where not everybody. You could have people with mild apnea that maybe don't need to be treated. I mean, this is where the research is trying to direct us. Mm-hmm. We do know that, in general, anybody with moderate to severe apnea by today should be treated.
Gotcha. Well, I think it's time for a little break now, so we'll take that and come back shortly and ask some more questions to Dr. Vasile.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
We're back from our break. This is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And we are here with our guest, Dr. Anthony Vasile, who's speaking to us on sleep apnea. We earlier went through some of the keys that a primary care physician can use to diagnose sleep apnea or to suspect sleep apnea, and weight is one of those. And with a BMI above 35, that makes you in danger for sleep apnea. When 45% of our nation is obese by definition, and that's I assume sleep apnea would be pretty high on the list in those individuals.
Obesity by definition is a BMI over 30.
Yes, 35 is the one we're looking for, right?
Well, I think 30.
30 could even come into it? Okay.
Yeah.
And the next size, in men it's 17 and in women it's 16?
16, correct.
Okay, I myself in the practice have patients like that, and I have sent them for sleep apnea studies. Now, let's talk about, we came upon an earlier discussion of the health risks of sleep apnea, and there are a lot of them. And, we went through the cardiovascular risks, the daytime somnolence and its potential dangers, falling asleep at the wheel, etc., and sudden death in certain individuals, brain fog, you just can't get it together. Any other things that may say, hey, we got a problem?
Well, if you look at people with underlying health issues, mm-hmm. what's the percentage of that group that has sleep apnea?
Okay.
Because, for instance, somebody who has drug-resistant hypertension, they're on 3, 4, 5 drugs. Mm-hmm. There's about 80% chance they have sleep apnea. Mm-hmm. So is treating the apnea going to make the hypertension go away? No. You may be able to reduce a drug, mm-hmm. but again, identifying it, because if you look at blood pressure studies of untreated apneics at night, mm-hmm. I mean, you see the spikes, and it's like, It's kind of scary.
Is it?
And for instance, we know that about folks who have clinical congestive heart failure have about a 50 to 70% chance of apnea. Atrial fibrillation, 45% chance of apnea. Hypertension overall, about 35% have sleep apnea. Mm-hmm. Morbidly obese, meaning 35% for BMI 35, 77%,
Wow.
75% have sleep apnea. And about 50% of diabetics have it. So if you took a male who's got type 2 diabetes in his 60s, I mean, what other test are you going to do that's going to have a positivity rate of 50 to 60%? Nothing, right? And the other thing we know about apnea is that the incidence of apnea is about 2 to 3 times higher if you're over age 65 than in the younger population.
Okay.
So, if you see a person with AFib, and again, this is why cardiology are kind of becoming big referrers for sleep apnea, because the AFib group, at least probably close to half have it. And if you fail a cardioversion, if you have untreated sleep apnea, you're more likely to fail a cardioversion.
That's when they try to shock you back. When
You're
in
right.
AFib.
Yeah, you're going to fail the cardioversion.
Mhm.
So, we know, for instance, that there was a study that looked at people admitted, I think primarily men, admitted with acute coronary syndrome, 65% had untreated sleep apnea or undertreated sleep apnea. The other thing is chronic kidney disease. About 50% have sleep apnea, and that they have about a 10 times greater risk of apnea than the general population. And believe it or not, fatty liver.
I see that a lot.
Fatty liver may have apnea, probably in that, I think it's 40 to 50% range, and it's probably some of this is what plays into the how low, what's the hypoxic burden, how low does the oxygen level drop for a period at night, that probably plays a role in this. So if you have these folks coming in with these diseases, you need to ask the question. You have to ask the question because they're not being adequately treated. Now the question is, just because they have the disease, does all apnea have to be treated? That's a question we're trying to. That's being debated. As now I'll talk about phenotypes, but if somebody's got minimal apnea and asymptomatic,
Sure. Off the subject, I read a nice article today about Cushing's disease and how Cushingoids are hard to have their blood pressure controlled. They're diabetics. They're obese. They also have sleep apnea, most likely.
Right.
Okay. All right. Let's move on to the next part of it. There are ways to test for sleep apnea.
Correct.
There's the home test, and everybody wants to do it at home, in my experience anyway. And then there's the in-center testing.
Right.
Give me the pros and cons of these, if you would, please.
Well, the in-center is the gold standard. It's what we did for many years. It's more costly, but it's the gold standard. In other words,
It's the best.
It is the best, but again, you have to go to a center. Sometimes you don't sleep as well. We have what's called lab effect. You have a bunch of EEG brainwave monitors on. You have a probe under your nose to measure airflow. You have a monitor on your heart. You have monitors on your legs for leg movements. You're sleeping in a strange place, so it doesn't necessarily mimic what happens at home, right? But it's the gold standard. It's the most expensive, and it's the go-to when you have to answer other questions. For instance, if they don't have apnea on a home test, let's say, other things we can detect on the in-lab, such as leg movements, seizure disorders, nighttime behaviors, if we're worried about something called parasomnias. So that's...
You can measure all that in a lab.
In the
you
lab.
Can't do that
right,
at home.
Right, correct. Now, the home test, it's simple. It's more cost-effective. It's convenient. And it's a great rule-in test. In other words, now, guidelines state that patients who don't have significant medical comorbidities should, you can substitute a home test. If you have congestive heart failure, if you have a neurologic disorder, it's probably not the study you should go to. And a home test is a good rule-in. If it's negative, the home test, it doesn't rule out apnea for a couple reasons. One, we don't know when you're sleeping because we don't typically measure sleep stage without EEG monitoring.
Mm-hmm.
Now, a couple of what we call portable monitors have an ability to give you a one channel or whatever, but it may not be adequate, right?
Mm-hmm.
So if you have a negative test with a high clinical suspicion, you go to the in-lab.
Okay.
The other thing is there's night-to-night variability that we know with home testing, so the recommendation is really to do 2 or 3 nights in succession and to mimic your behaviors at home. People who have alcohol-induced sleep apnea, they don't drink in the lab. Well, you're going to miss it, right? But that's, with the home testing, what drives it, why home testing, the other part of this is it's insurance company driven.
Always,
so,
everything.
So if you look at the criteria, even on the insurance companies' websites, this was when home testing really started to take off several years ago. It said if you have congestive heart failure, if you have neurologic issues, you should have an in-lab. But they would deny it. So you end up stuck, or central apnea suspicion, you end up stuck doing the home test.
And hoping for the best.
Well, and the other thing, too, is if you have a negative in-lab study, that's not the be-all, end-all. If there's a high clinical suspicion and you had a negative study, the recommendations are you repeat the in-lab.
Got it.
Got
it. And in the in-lab, you can make some tweaks to the machinery to figure out possibly the pressure you're going to be looking for?
Well, it depends if you're going to do it as a treatment, right?
Okay.
I mean, so treatment is if you meet certain criteria where you have significant enough apnea, typically 40 events an hour, pretty severe. In the first couple of hours, you can do what's called a split night, where you the second part of the night, you treat them, you put CPAP on.
Got it.
And there are some recommendations as well that in doing a split night study in the appropriate population, ordering it as a split night is reasonable.
Okay. Okay, but now let's just look at this. Hey doc, I can't fall asleep unless I take melatonin or I take some sleep aid.
Right.
They can't take that during testing, can they?
That's not true.
Okay.
We do know, for instance, that with home testing or with testing that we do have folks that don't get adequate sleep because you need to have adequate sleep for a legitimate study. Adequate sleep is about 4 hours.
Okay.
So we do know that the non-benzodiazepines, the zolpidem, Ambien,
melatonin,
right?
Ambien, things like that.
Not melatonin, but the non-benzos.
Okay.
The non-benzos, the esopiclam, which was Lunesta. They don't affect sleep architecture, so they don't suppress REM, things like that. So those we do use in the laboratory setting if someone has a failed night and has to come back. We will recommend a hypnotic agent. And there's protocols to follow about dosing and is somebody going to pick you up. And if you have melatonin, we ask folks to mimic what they do at home. So if they have to take melatonin, if they're on alprazolam, we ask them to take it. And we try to...
With alprazolam, even though it's discouraged, right? Benzos are discouraged.
Well, but they're on it for a reason, right? Or a Tylenol PM. I mean, because we're trying to see what's happening, and if you have someone who is using this for a sleep aid, and then you're not giving it to them, the chances are their sleep quality is going to be
Does
less.
it really interfere that much with the testing?
Well, if they have apnea, not likely.
Okay.
But it's going to change the stage of sleep, whether percent of REM sleep, percent of stage 2 sleep, things like that.
Got it. Okay. Well, thank you for that information. All right, now we know that we've discussed mild, moderate, and severe apnea, hypopnea, the apnea-hypopnea index. And could you go over that one more time? Greater than 5
5
events?
is apnea.
Okay.
Over 15 and above is moderate, 30 and above is severe apnea.
Got it. All right, now let's talk about what we do after we've made the diagnosis. We have numerous ways to approach this. some people say, can I avoid the machinery because my neighbor can't do it? He has CPAP. His wife can't sleep. He had to move to another bedroom, yada, yada, yada. Is there anything else we can try? Now, there's out there, in the olden days, they tried uvuleplasty too, right? Is that
Yes.
true? And that was a very painful surgical procedure, which they removed the uvula, and it didn't work.
Right.
Then they go to their dentist, and he says, I can give you an implant that can pull your jaw forward and take away that obstruction, which is basically the tongue relaxing and going back and obstructing the airway. Does that work?
Well,
I'm looking for reasons other
right.
than the machinery.
So let's talk about CPAP. Mm-hmm. The most effective modality, without a doubt, is CPAP, or we don't have to get into BiPAP, but basically positive pressure. Mm-hmm. Simple mechanical principle. You put a device, a mask, use the mask there's many different styles that traditionally went over the nose, gives positive pressure to help splint the airway open. It's very successful. Mm-hmm. But tolerance is the issue. If you look at compliance with CPAP, it's not great. I mean, it's above 50%. And if you're really tightly manage the patient and explain things and the patient's motivated, you can have very high compliance with. But also, the patients have to feel the benefit, right? So CPAP, without a doubt, is so. The way I approach it is that folks say, my neighbor can't stand it, my wife can't stand it. Like, well, you don't know unless you try. So part of the issue is the one thing we didn't talk about is there's two ways of using CPAP. One is doing in-lab titration. You bring them in, they're educated by the technician. We start with low pressures and then titrate it up to eliminate the apnea, eliminate the snoring. You find a mask or a device that either goes over the nose or over the nose and mouth that's comfortable and works and doesn't create leak. And so that's the best way to go, but it's not for everybody. Mm-hmm. So you at least try it to see, how do you tolerate it in the lab? Mm-hmm. There are folks that have a lot of claustrophobia that can't do it. We understand all that, and that may not be appropriate, especially if someone's tried it before and chances of success are going to be lower. The interface, the nasal interface, the mask is really an important part of that. Mm-hmm. And then BiPAP may be better tolerated than CPAP. So
what's the difference?
BiPAP,
for the lay people.
CPAP is continuous positive airway pressure. Mm-hmm. So you put it on and you have the same pressure when you breathe in, breathe out. It's 5, 10, up to 20 centimeters of pressure. Mm-hmm. BiPAP is what's called bi-level. You get a higher pressure when you inhale, and the pressure is dropped on exhalation. So it is, in a sense, a non-invasive ventilator to some extent, right?
Agreed.
And so it can be more comfortable, and it can be more effective than CPAP in certain circumstances.
But you still got that claustrophobia.
You still have it, right.
Mm-hmm.
So part of the reason to consider a trial of BiPAP, because the insurance company, or CPAP, BiPAP, the insurance companies give you 90 days, that includes Medicare and the privates, to become compliant. You have a 90-day window, which means that over the course of a month, any 30-day interval of that 90 days, you have to use it for more than 70% of the nights for 4 hours, which is not a tough
thing to do.
But you'll at least get a sense of, is this going to work for me or not? Because if you don't meet the criteria within 90 days, or you find it's something else, you can go to another treatment option, which we will talk about, the oral appliance. However, so you have 90 days. But if you sign on to CPAP and you meet the criteria from a DME, durable medical equipment, you got it for 5 years. You can't go in another direction. So if you decide you're going to pursue an oral appliance, it can be tough getting it fitted and approved within 90 days. Well, then, if it doesn't work, you're stuck for 5 years unless you want to pay for CPAP out of pocket.
Really? So if you get your dental implant approved and it doesn't work,
you're stuck.
Wow, that's not a good
So
thing.
now, in general, oral appliances are indicated for mild to moderate apnea. There is an indication now for severe apnea for folks who can't tolerate CPAP. They work about 50% of the time.
Okay.
And you're not really going to know who it's going to work on unless you try it. And it's all about, moving the jaw forward. There are some devices that pull the tongue forward like a suction device. They're not maybe as well tolerated. The dentists need to be experienced, ideally sleep certified. There's a lot of dentists who will make an attempt at an oral appliance, but you need somebody with experience.
Understand.
And we use oral appliances. I mean, there's no doubt about it. And like I said, CPAP's not for everybody, and you need to have other options.
Can you use both?
Yes, in some circumstances, it has to. If you can't manage the apnea because the pressures are too high to tolerate, but the appliance doesn't work, or isn't as effective as it could be, there are instances where there are folks that use both.
Gotcha.
But the out-of-pocket, the other problem with dental appliances is the out-of-pocket expense, because a lot of dentists do not take medical insurance. The oral appliances are considered a piece of durable medical equipment. It's not covered by dental insurance. So the hoops you jump through with medical insurance. A dentist, they use some dental insurance, but they're not going to sign on for. Now there are some dentists. There are dentists that do bill insurance, and that's the ones we tend to use, and they have the most experience, and they tend to do well. Do they do Medicare? This is another story. There's a lot of hoops to jump through. But overall, an oral appliance works about half the time. There are downsides, right? TMJ, dental movement. But it is interesting because I talk to people about, here's our treatment options. They're not putting anything in my mouth. You'll hear that too. It's not. There are people that are adverse to oral appliances. So
now
I'm not poo-pooing them. They clearly have a role, and we do use them. But realize it's a coin toss as to whether it's going to work.
Gotcha. An extreme in a severely affected patient, a tracheostomy would be the ideal thing and would overcome the pressure. You don't have to worry about anything, but who wants a hole in their neck, right?
The last trach I saw was when I was a pulmonary fellow.
That was it, and was it for that?
It was.
That's extreme, but
this was the early days. This was the mid '80s, the early days of sleep apnea. Yeah. So trachs do work. But there are better options.
I understand. Now we have something called Inspire. We hear the commercials.
So
talk to me a little about that.
Right. So Inspire is an implantable device. It is a pacemaker that stimulates the upper airway, the hypoglossal nerve, that if you feel around your neck above your thyroid cartilage, you have that little U-shaped bone in there. Yep. So you stimulate the tongue when the person breathes in. So there's a sensor that goes up that stimulates the hypoglossal nerve, and then there's a sensor that's implanted on one of the intercostal or between the rib muscles. So when the patient breathes in, it sends a stimulus to stimulate it, and
to push its tongue forward.
Yes.
Got it.
And so the Inspire, so it is a foreign body. It is a piece of hardware. It's a pacemaker. It's turned on with a remote control. That's what they show you on the commercial. So the criteria for an Inspire are ideally you don't tolerate or will not use CPAP. You have to have apnea of at least moderate severity done within 2 years, about 15 events an hour. The key is your airway collapse has to be front to back. In other words, it's simply imagine that the tongue just drops back. A lot of folks have what we call circumferential occlusion, where imagine your hand is it squeezes closed. It doesn't work for that. Circumference. So what's done as part of the screening is they do a sedation endoscopy to see. The ENT docs are the ones doing the procedure, and then there's also a BMI requirement. There's a little difference between Medicare and the privates, but ideally you want the BMI under 32. If you meet those criteria, under 32. Mm-hmm. If you meet those criteria, that the success of Inspire is about 90%.
Really?
So it does work. It is expensive, but
that's higher than all the other potential possibilities, right?
But if you meet the criteria, front to back collapse is the game changer.
I got you.
Okay,
I got you.
And you have to have a BMI that's in range for insurance purposes.
Well, what was
and
CPAP?
they used to say that, and again, there was a range for the severity of apnea, at least 15 obstructive,
mm-hmm.
and but now there's not really an upper range now.
Okay. Well, CPAP, what was the percentage of successfulness there? You said 50 some?
No. I said compliance.
Oh, compliance.
Oh, it's very effective.
It's very effective. So, okay, it's very effective, but compliance is bad. Inspire is, most people would say, oh, I'll deal with that because I don't have to have a sting on my face.
Well, but there is getting used to, right? I mean,
mm-hmm.
you're getting electrical stimulus, so there are folks that find that uncomfortable.
I have one that I know very well.
But it is being done in the community. The ENT docs,
mm-hmm.
We have a program. And
what is the cost of an Inspire? Do you know? I mean, just curious.
It's $40,000 to $50,000.
My God, that's
so it's got to be insurance approved, right?
Oh yeah, for sure. Nobody's going to pay for that just to get a little machine to push your tongue forward.
So now, if you want to get into some of the other treatments,
go ahead. Let's go.
So you talked about the uvuloplasty, but the traditional sleep apnea surgery is the UPPP, the uvulopalatino-pharyngoplasty, where you remove the tonsils, you remove the uvula, you remove the tonsillar pillars. That surgery is roughly 50% effective, and 50% effective means there's a significant improvement, but not elimination of the apnea. And over time, there can be relaxation of the airway. So a couple of years, it could. And so it's a tough procedure.
People tell me they would rather put a poker in their eye
than do it again.
Right?
A tonsillectomy is tough enough in an adult.
I know.
But simple things too, right? If
mm-hmm.
somebody's got big kissing tonsils,
mm-hmm.
a simple tonsillectomy can be reasonable. If they have significant nasal obstruction, certainly we work with our ENT colleagues to see.
I had some children
mm-hmm.
that had such huge tonsils and adenoids that they had sleep apnea.
Right.
And they had them removed and went away.
So the treatment of choice for pediatrics,
mm-hmm.
Is tonsillectomy.
Mm-hmm.
Even though there's a significant obesity rate in this country, so we are seeing more non-responsive to tonsillectomy.
Mm-hmm.
The other thing is that in the pediatric age range, it's a different criteria. Over 1 event an hour is apnea. Over 10 events an hour is severe.
Wow.
So, but there's also now some data that looks at watchful waiting, that the apnea can go away over 6 or 12 months just by observing. So they need follow-up, and so typically that's the folks over at the Children's Hospital or the ENT docs and
uh-huh.
the sleep clinic.
Yeah, I've had a couple of kids that had this.
So that's a different
ball game.
That's a different ball game.
All right. Anything else?
Yes. One of the things that we are but in certain groups there's something called positional sleep apnea. So if folks, typically this is supine, you're lying on your back.
Mm-hmm.
So if most of your apnea is on your back, then using a device for positional therapy to prevent you from rolling on your back can be very effective.
I used to tell people, put a
tennis ball in the middle of your back.
Of your night clothes, you roll over, you roll back.
Right. So the problem with the tennis ball is it can be effective, but you're relying on the patient to do it. And the other thing, too, is when you're rolling on your back, the reason you're rolling back over is because you're getting your sleep disrupted from the tennis ball jammed in your back.
Yeah.
So there are other devices that are out there today. One of them is the Zoma. There's the slumber bump. These are devices you wear. Some are inflatable, some. and actually the Zoma met FDA approval for actually approved for management of mild sleep apnea.
What is a Zoma?
A Zoma is a device you just basically strap it on, and it has a cushion in the back, so it prevents you from rolling on your back. Okay. You can go side to side by rolling on your stomach.
Okay.
So these devices now, it is only very recently they were out of pocket expenses because they weren't approved. They are now approved. Okay, this is all within this year. But from a cost standpoint, they're pretty cost effective. Mm-hmm. I mean, they're anywhere from $60 to $200 depending on the device. But not everybody tolerates them.
Everybody sleeps on their back.
Well, no. You want to keep them off their back.
I mean, I know.
Yeah,
but
some people, right, and some arthritis and back pain. So things factor in, and some devices are more effective than others.
Okay.
But positional therapy is, obviously simpler the better. And if someone does have positional therapy, how do we know if it's effective? Well, we would do a follow-up, typically home test to see the efficacy, if it works or not.
Got it. You would recommend that for the mild to moderate?
Right. And we've tried it in sometimes a combination, CPAP and positional therapy, depending on severity. The other thing, too, to keep in mind is that it's not one size fits all. We also pay attention to what's the oxygen level doing at night. And in certain types of apnea, some of these less invasive things, like an oral appliance or positional therapy, if the patients are kind of hypoventilating a little bit, meaning they're shallow breathing and their oxygen level staying down despite a little, you have to follow these patients. Mm-hmm. So they may need follow-up pulse oximetries, follow-up sleep tests. You need to monitor efficacy. Now, oral appliances quickly. How do you know if a person with an oral appliance is compliant?
Right.
Well, now there's software and chips being put in these appliances to show that patients are using them.
Wow.
And then lastly, maybe the best thing, patients would come in and say, do I have to wear CPAP the rest of my life? My answer is probably not, because there are now starting to look at drugs to maintain upper airway tone at night. So there's actually been a study that looked at a combination of two drugs. One was eroxybutynin, the bladder drug, in combination with tamoxifen, the ADHD drug.
Wow.
And
oxybutynin is one?
Combination. The problem is the side effect profile. One's anticholinergic, and the ADHD drug's a norepi uptake inhibitor. So the side effect profile can be brutal. But in the study that was done, patients with mild to moderate apnea had 77% of them had an AHI of under 10 on therapy. Moderate was less impressive, 42%. Severe apneics, only 7% got to less than 10.
Interesting.
But the point is, that's the future, right? Pick a drug, monitor the side change or whatever to help with side effect profiles, and that's where. And hey, weight loss is a big deal too, right?
Oxybutynin, for one, is an old drug.
Yeah, but you're not
used for bladder problems.
Correct.
And I have people on that. I'm going to start to ask them questions if they also have apnea, if they have better sleep.
Yeah, but I wouldn't. This is one study, one drug that's been through phase 3 trials, but there are going to be folks that are going to respond, right? Who don't have. But one thing, the plug for obesity, right? 10% loss of body weight, 25% improvement of sleep apnea.
Wow, that's
10% gain in body weight, about a 32% worsening of apnea.
Wow.
So bariatric surgery can be very effective, not 100%, but weight loss is still important.
Very important.
Can be very important.
With these newer drugs that we inject for weight loss, the GLP-1s, very effective. I've used them on a fair amount of people.
Right.
Very effective.
And there are some studies showing that we are seeing improvements in apnea.
I would imagine, because you're reducing one of the biggest risks is obesity anyway.
Right.
All right. Anything else you would like to bring forth? I'm very interested in some of these things, like the new possible drugs that we may be able to use for this.
Yeah, I mean, that's down the road.
I'll
right?
be honest with you. I have lots of people, well, a fair amount of people with sleep apnea. Compliance in my idea is that there is hard because they say, Doc, I just can't take this anymore.
Well, I mean, I can tell you that there are going to be those folks, but really the best, in my opinion, the best chance of success with CPAP is the patient needs to be monitored on a regular basis by someone who's experienced in looking at the data and folks who can look at the issues as to why is compliance slipping, what we call remote patient monitoring.
Mm-hmm.
That's really, and you're right, compliance is always an issue.
Wow, this has been a very interesting discussion, Tony. I really appreciate it. Is there anywhere we can get some contact information, how to get them hooked up with your center or information on sleep apnea that they can review themselves?
I think Delaware Sleep Disorder Centers or delsleep.org.
Delsleep.org.
The AASM, the American Academy of Sleep Medicine, has information.
Okay. Very good. I think we did a good job here today discussing sleep apnea and touching all bases, and I appreciate your cooperation with this, Tony, and I hope to be seeing you soon to go out to dinner with you and your wife and my wife.
Good.
Sound good?
It sounds great.
All right. This is Dr. Nick Biasotto. This is our completing our sleep apnea interview with Dr. Anthony Vasile, which was very interesting. The season is here. It's Christmas and New Year, so we will probably be picking up our next interview in about 2 to 3 weeks after the holidays so that we can all have a good holiday and not have to worry about preparing anything. So enjoy your holidays, everyone. This is Dr. Nick Biasotto signing off from the Medical Society's podcast, Delaware Healthcare Reality. Have a good holiday.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.